Okay, should I start over again? No, just kidding. Now I just lost my screen. No, I'm not starting over again, but I did just lose my screen for some reason. All right, sorry about that, guys. So if you leave your radio, I'm not really gonna go back to slides, guys. If it's all on the web. If you leave your radio in the ambulance and somebody breaks into the ambulance and steals your radio, you're going to be getting a very slim paycheck for many, many weeks, because most agencies are going to hold you responsible for it. So it's very important that you secure that radio, and for your own safety as well. Plus, a lot of the radios can also get police frequencies, police transmissions, so you don't want to get caught up in losing that equipment. All right, just give me a minute while I try to fix this here. It is actually illegal to monitor and to hack into police and frequencies if you're not licensed by the FCC. Not that anybody's ever going to catch you, but just a point of view. Guys, you may want to take a minute break. I think I may have to sign off and back on again. Sorry about that.
Did he just say 30 minutes?
No, 1 minute.
No, he said
Oh,
1
I was
minute.
about to say less.
Damn, Nathan, you just wanted to just say 30 minutes?
Is this recorded?
Yes.
I
think-
Yes.
1 minute.
Sorry about that, guys. Can you hear me now? All right. Let me go back 2 slides. That's not really necessary. All right. So when you're giving a report to the hospital that you're delivering the patient to, some hospitals want a report from every patient. Some hospitals only want reports for very critical patients. For example, in New York City, if you want to give a notification, most hospitals don't care unless it's something that's stable or unstable or critical. Out here in the island, there's hospitals like South Nassau and Good Samaritan. They want EMS calling in every single patient that comes through those doors. What's the reasoning behind that? I don't really know, because a critical patient could be just as likely to walk into the back door as they could be to arrive by ambulance, but that's what they like. So if you're going to give a radio report, start off by identifying yourself, meaning your unit number, to the dispatcher. Giving an estimated time of arrival is kind of debatable because most studies find that those things are not very accurate. What's the difference if you arrive in 6 minutes versus 8 minutes? You know, there can be so many confounding factors that can interfere with your ETA that don't get too hung up on it. Patient's age and sex, 54-year-old female, for example, chief complaint, complaining of chest pain, brief pertinent history of the present illness. So too young to dispatch. I'm en route to hospital 83 with about an 8-minute ETA with a 56-year-old female complaining of chest pain, onset at rest, associated with nausea and dizziness with a positive history of 3 MIs in the past. So you kind of get the story there. You don't got to give them every single detail. Well, she was sitting on her couch watching her favorite soap opera, eating a burrito. No, it's just very, very short and sweet and simple. ANO times 3 with a blood pressure of 150/90, pulse rate of 110 and regular, respirations are 18. Pertinent findings on physical exam. She appears a little cool, pale, diaphoretic, exhibiting positive Levine sign. Anybody know what positive Levine sign is? Extra, no points for you. We given her 2 baby aspirins and one of her pre-prescribed nitroglycerin with no relief. We have her on oxygen, no relief. And of course, if you need to contact medical control, you let them know what other instructions you were given. It takes practice. Right? Nobody's going to get it right and be comfortable with the first time. So calling medical control, for example, can be very scary and intimidating first few times, but you got to know what you're doing. Give your information clearly and accurately. After receiving an order or denial for a medication, repeat it back word for word. That's something in medicine we call closed loop communication. And most importantly, that's to prevent medical errors. So if your medical control physician tells you, EMT Young, please assist the patient with one of their pre-prescribed nitroglycerins sublingually, you respond, yes, sir, yes, ma'am, I'm going to confirm I'm administering one of my patients sublingual nitroglycerin and word for word. Do not be shy or intimidated if you did not pick up on the order the first time and you need to ask the physician to repeat. And this is an important concept. If the order seems inappropriate, question the physician because it's ultimately your butt on the line if something goes wrong. So if the physician tells you to, I'll use nitroglycerin because it's an easy example, to assist a patient with their pre-prescribed nitroglycerin, they have to have a systolic blood pressure of at least 120. If your patient is hovering around the 90 systolic mark and medical control tells you to assist them with the sublingual nitroglycerin, sir, do you really mean for me to administer the nitroglycerin? Let me remind you that the systolic blood pressure is only 90. Most of the times it's just a communication error. But also remember that if medical control does truly advise you to do something that you feel is going to be detrimental to your patient, you need to refuse it, but you need to justify why. So you really got to know your stuff. So as far as giving a verbal report at the destination, talking to the triage nurse, the charge nurse, it depends. Some triage nurses want a full presentation. Some triage nurses just want to get you out of their faces and sign your paperwork. It's different every place you go. But the proper way is upon arrival at destination, introduce the patient by name. This is Mr. and Mrs. Smith. Give complete and detailed report. Mr. Smith started experiencing chest pain while sitting down, watching TV 2 hours after eating dinner. Says the pain is sharp, non-radiating, associated with nausea and vomiting. Took 2 of his nitroglycerins at home, got no relief. We gave him an additional nitroglycerin. When we got there, no relief. We also added a single baby aspirin and oxygen, no relief. Physical exam on scene shows he was cool, pale, diaphoretic, leaning forward in a tripod position. Conditions remained unchanged. Vital signs were this, and that. En route to the hospital, and here we are. And I pretty much just went through all of that. Okay, this video will not play on Blackboard, so we're going to skip over that. Let's talk about interpersonal communication, because that's something that can always be improved upon, no matter how much time you got in the field. EMTs must communicate with others involved in patient's care. Other EMTs, first responders, family members, law enforcement, medical personnel who's also in charge of the patient. Maybe you're picking the patient up from a doctor's office, from a nursing home, from another hospital, doing an interfacility transport. Always be candid, meaning talking about what's pertinent to the patient, and respectful. Collect the information about the patient. Okay? You're going to be responsible for everything about this patient for that time that you're in charge, regardless of what medical interventions, what advanced medical interventions they may have had prior to you picking them up. For that 10, 20, 30, whatever minutes that they're in your care, it is your patient. You are ultimately responsible. Communication techniques learned by experience may be more difficult than those in crisis. Yes, you're going to learn that when the shit hits the fan, voices get loud, attitudes get terse. It comes with the job. And it's kind of important to kind of develop a thick skin and not take these things personally. Everyone can improve communication skills. When the slide tells you to use eye contact, I tend to take that with a grain of salt. Yes, you've probably all been to a doctor's office or a hospital or been a patient, and the person looking at you is just talking to the computer or talking to the clipboard or talking to the chart and have very little awareness of your existence. Showing eye contact shows that you have interest in the patient, that you're actually involved in their care. But you got to be careful, because there are some cultures, some societies that take you looking them directly in the eye as an insult or a challenge or disrespect. So just try to be aware of that. Be aware of your position and body language. You never want to stand over your patient with your arms folded, showing like a very tough guy appearance. I mean, look at the picture here. All right, so you have an EMT, you have what appears to be a frail elderly patient, probably looks a little scared, doesn't know what's going on with her, and you have what looks to be a very concerned family member as well. What's the EMT over here doing? Is he standing over the patient like an authoritative figure? No, he's crouching down and kneeling at eye level, even a little bit below eye level, comfortably holding her hand and talking to her. And your body language says a lot about how you present yourself as a professional. So just keep that in mind. Use language patient can understand. If you think they're having a heart attack, please do not say, well, I think you're having a vasospastic thrombogenic event in your left anterior descending coronary artery. There's some assholes that like to talk like that. Baffle them with their bullshit. You're not doing anybody any favors by doing that. Just, you'd be surprised. And be honest. Don't tell a patient that they're not going to have to stay in the hospital just to get them to go, because you're just going to make your life more miserable in the future, and the lives miserable for your coworkers when you have to see that patient again, and now they really can't get them to accept care because of the lies that you told them. If something's going to hurt, don't tell them it's not going to hurt. If you have to straighten out a broken bone to put a splint on it, that's going to hurt. It's going to hurt a lot. You could be tactful. You could say, listen, I'm going to do my best. I'm going to try to make this as comfortable as possible, but this may hurt for a minute. Please bear with me. Do whatever you can, but don't lie. Use patient's proper name, sign of respect. Always address your patient as Mr. or Mrs. So-and-so. Now, personally, if I have a patient that has a very complicated last name, I may refer to them by their first name, but put a Mr. or Mrs. in front of it just to show respect. So, hi, Mr. John, I'm Steve. I'm a paramedic. I'm here to help you. What's going on today? And listen, especially when you have a medical patient, okay? When you have medical patients, like a diabetic emergency or respiratory, everything you do for that patient is based on the information you get as you're listening and communicating with that patient. Special considerations to always be compassionate, empathetic, and respectful, especially if there's a mental disability, such as autism or Asperger's. If they have a visual or hearing impairment, you need to be patient. Language barriers can present a problem. Most EMS agencies have contracts with language interpretive services. So you may have to contact your medical control for them to patch you through. It's not always a good idea to use a family member as an interpreter, because unless you speak that language, do you really know beyond a shadow of a doubt that that's what they're telling you? Got to play a little cynicism from time to time. As far as pediatrics goes, again, as I mentioned before, try to make them as comfortable as possible. Get down to their level. Don't stand over them. Don't try to show off you're so much of a tough guy. When you're communicating with a pediatric patient, don't disregard the parent either. It's kind of a little fine art. You want to ask, depending on the age appropriateness, you want to try to get the history from the child. Obviously, you can't get a history from a 6-month-old, but a 4-year-old you could get a little bit of a history from. You can ask them, where's the boo-boo, or what hurts, or what's wrong, and try to get a history from them, and then go back and verify with the mother or the father or the caregiver. It takes practice like anything else. Okay, so let's talk about the pre-hospital care report itself. The documentation that I mentioned is so important. When you go to the doctor's office or you go to the hospital, and 90% of what the doctor or the nurse or the PA or anybody who's taking care of you is doing is clicking away a computer or writing in a chart. And there's for several reasons. Okay, most important is that it provides a tangible means of communication of that encounter down the line between other healthcare providers, the same healthcare provider, because if I'm seeing you in the office and I saw you a year ago on top of the 10,000 other patients I saw within that year, am I going to remember everything from that last encounter? Probably not. Okay, so there's many different reasons for that documentation. Written documentation of everything that happened during that call is key to protecting you from a lawsuit. And there's several methods by which that happens. Traditionally, handwritten paper PCRs have been used for years. That's kind of falling out of the wayside as technology is getting better, and we're going more and more to electronic charting devices such as laptops and tablets. I really haven't seen any pen-based computers out there in any field. I guess they are out there. But by and large, tablets and paper PCRs are the most common. Paper PCRs being kind of fallen the way of extinction. And for good reason. I mean, as far as paper charting, handwriting is always an issue. 50 different agencies can have 50 different types of PCRs. But they all pretty much follow pretty much the same set of rules. Document all the findings and treatment. If I'm your medical control physician and I want to see what you've been doing with that patient, it helps convey a picture of the scene. Consequently, if I'm a lawyer looking to sue you, it also paints a picture of that scene. But the more detail you put into that PCR, the more likely are you going to protect yourself. Remember my story in the emergency room. If I didn't document every single physical finding, every single procedure, every single conversation I had with consulting providers, it would have reflected poorly on me. A lawyer once said, if you didn't document it, you didn't do it. That's probably the only one time I got burned in the field from a complaint that was really initiated by my partner. My call came up for review, and I did everything appropriate. However, I forgot to document the oxygen on the PCR. I know I gave it to the patient. But for some reason, had a brain fart. I did not scribble in that little 15 liters per minute in that box on that paper, and that's what I got dinged for. So no matter how much I said this, yes, I gave her oxygen, yes, I gave her oxygen, according to the higher ups, you didn't give her oxygen, and I got dinged. Time in 30 years. It happens. So document the findings and treatment, conveys a picture of the scene, and the documentation that you take down in the field and submit to the hospital is part of that patient's permanent medical record. Just like their ER encounter, just like their floor encounter, just like their neurology consult, their psychology consult, just like their specialty consult, it all goes into their record. And it is a legal document. It can be subpoenaed and used in evidence. It could be used to sue you, but it could also be used to protect you. Again, I think in New York State, the statute of limitations is 7 years from the call. So you could be called as a witness up to 7 years from that encounter. So again, are you going to remember that encounter 7 years down the line? And it's usually not the real traumatic calls, I find, and this is subjective, but it's usually not the most traumatic, hard-hitting calls that are ones that are taken you to court. It's usually the more boring, mundane ones that you probably never even thought about until you got that call from the lawyer. So do your best to describe it all accurately and precisely. It's used for administrative purposes as well, to get insurance information and billing. And yes, most ambulance agencies try to collect billing and revenue. They will bill the patients, they will bill the insurance companies. Most ambulance agencies will take the hit if the patient's not able to pay for their services. Most of the times, insurance will cover some, if not most of it. But every ambulance company, whether it's municipal, private, voluntary, needs to pay overhead. They need to pay the rent. They need to pay the electric bills. How are they going to do that? Some places get donations. A lot of places don't. So it is what it is. Your documentation is very important for education and research. As I mentioned day one, continuing medical education is very important in the field of EMS. So a lot of agency and hospitals will hold what's called CME, continuing medical education, call review. They'll invite EMTs from their agency and from other agencies as well, and they'll go over certain calls using the paperwork and discuss what happened, what was good, what could you be improved, and so on. It's for growth and expansion. This is what I just mentioned. This is very, very dry, non-pertinent stuff, but you still got to know it. The elements of the PCR are all basically dictated, regardless of the PCR you use, whether it's a city, state, municipal, private. There are certain elements that are pretty standard, one of which is the National Highway Traffic and Safety Administrator standards for minimum set data, response times, response address, things like that. The run data, which includes the agency name, date, times, call number, unit personnel, level of certification, other information mandated by the service. The way I like to teach this course traditionally is do a little role-playing scenario where two EMTs would come up, be the EMTs, we would have a simulated patient. Sometimes I would even give a volunteer for my first aid class for extra credit to really get into character. The EMTs would play out the call, and then it would be your jobs to document that call on the PCR. And then we practice it, we put it up on the board and go over it. If we get a chance to do that this semester, it'll be great. Otherwise, you're gonna just have to really kind of use some examples there. I mean, a lot of the PCR is pretty self-explanatory. All right, where it says name, put in the patient's name. Where it put address, put in their address. Whatever you can put in, put in. What's really kind of the meat and potatoes of the PCR, pre-hospital care report, is what's called the narrative. Your recap or your accounting of what was going on with that patient. The little thing that you write in that's not self-explanatory. Where it says blood pressure, you put in the blood pressure. Where you put in pulse, you put it in pulse. That's self-explanatory. Where it says subjective assessment, that's more of an art. That's more of getting your thoughts together and writing down, almost like you're writing a book of all the events that occurred from that patient while they were in your care. The narrative can really be divided into two separate sections, the objective and the subjective. So kind of like your patient assessment. We'll start first. The subjective is obviously interpreted by opinion. It's reported by the patient. It's everything that the patient recounts what was going on, or the history of present illness. So your subjective part of your PCA, you'll write, so I have a 54-year-old female who was complaining of chest pain onset, 20 minutes, while at home, took 2 aspirin with no relief, pretty much like that. where the objective goes more hand in hand with your physical assessment, what you see on that patient, how that patient was found, sitting, standing, walking, their level of distress, appears comfortable, appears in distress, clutching a chest, cool, pale, diaphoretic, actively bleeding from their radial artery. It's whatever you find at that moment. So, and again, it takes practice, but objective is, like it says there, observable, measurable, verifiable, like vital signs, physical signs, things like that. Subjective is more what the patient tells you. You already know what the chief complaint is. It's what the patient tells you is the main reason for calling you there. When you're writing your subjective, it's also important to understand a concept of what's called pertinent negatives. Pertinent negatives, what does that mean? Well, for example, your patient's having chest pain, radiating to the left arm, onset at rest, described as sharp and stabbing. So what are we thinking? We're probably thinking probably a heart attack, probably. So what are some other things that occur with a heart attack? Well, are they they have shortness of breath? No. Are they dizzy? No. Are they nauseous? No. It's important to document the absence of those associated signs and symptoms. Okay? Because that paints a more complete picture to the person who's receiving that information on the other end. It's very important to avoid writing radio codes. So, for example, every agency has different radio codes. So 1063 might be en route to the job. 1084 might be on scene. 1020 might be delayed on the job. But what's true in New York City is different in Nassau County and different in Rockland County. Yet it's all New York State. So if that PCR goes to court, the lawyer's going to ask you, what do you mean you're 1084? I don't understand what it means. You on the scene or not on the scene? Well, on the scene in New York City, but now you're being called to court in Albany because it's a state issue. Avoid radio codes and non-standard abbreviations. Very important. There are medically recognized abbreviations, and then there are non-medically recognized abbreviations. Being that the trend is going away from paper PCRs, it's usually best to avoid abbreviations altogether. Like when you're examining a patient and you're checking for distal PMS. Well, what does PMS stand for? Do you think? Nobody wants to take a stab at that? Time of the month. Well, Jung-Sung, you're actually 100% right. All right, most EMTs think PMS stands for pulse motor sensory, but legally, the term PMS only stands for premenstrual syndrome. So if you're writing that you had a 34-year-old male with positive PMS in his lower extremities, well, 34-year-old male menstruating or premenstruating? No, it doesn't happen. Men don't get PMS. Well, they actually do. It stands for something different. Yeah, it stands for penis must suffer. But that's a whole different story in and of itself. Another inappropriate abbreviation, vital signs, WNL, which some people would think within normal limits, although what's normal for one is not normal for another. What would a lawyer interpret WNL as? A lawyer might interpret it as, we never looked. You might laugh, but it's true, because there is no such medically recognized abbreviation of WNL. So don't use it. It's tempting if you're using a paper PCR, you have to write within a limited space, although paper PCRs also come with addendum forms or continuation forms, and your agency should provide you with that. So there's really no excuse. And in electronic PCRs, you almost have an unlimited room to document your whole narrative. You could basically write the whole Homer's The Odyssey on a computerized tablet if you needed to. Not that I would recommend that though. But here's the golden rule at the bottom of this slide. If it's not written down, you did not do it. So document, document, document. We'll just go over a couple of special documentation issues. Confidentiality is very important, and we didn't talk about it. We have to talk a little bit about the Health Insurance Portability and Accountability Act. That deals less so with patient confidentiality as it does securement of identifying data. So back in the old days, we would do a paper PCR, we'd write all the patient information in it. We may throw it on the dashboard under the window of the ambulance to work on the next one, right in full view. We never really thought about it. And that was a major HIPAA violation at this point. All documents with identifying patient information need to be secured and sealed. Failure to do so can result in not only agency fines, but in personal fines as well. If a patient's refusing care, and we kind of discussed over this a little bit in some of those discussion questions, it's a high liability situation. Document all details in a refusal of care form. It is not enough just to have them sign the back of the PCR saying, I refuse care. Did this patient understand the implications of refusing care? Did you make the effort to explain to the patient the risks and consequences of refusing care? Like that patient that got hit in the head with a lead pipe. Maybe you did, but if you didn't put it down on that paperwork, in that document, lawyer's gonna say, what were you thinking? So take the time out to document. Don't ever cover up errors. If you wrote something wrong on the PCR, patient had a gunshot wound to his left forearm, but you meant right forearm, don't scribble out left because it looks like you're covering something up. Simply put a line through it, initial it, and then write the correct term. Maybe a little easier on a computerized document where you can erase it before it's submitted. But once that paperwork is submitted, whether it's submitted by hand to the triage nurse or it's the button has been pressed and it's been transmitted to whoever it's being transmitted to, you can correct the errors, but you have to do it as an addendum after the fact. So don't try to go back and correct those errors, especially on an electronic form, because it usually can be retrieved. Documentation errors occur. That's not a problem. Just don't make it look like you're trying to cover it up. All right. Any questions so far? And these are all real rhetorical questions that we're not going to get into. Multiple casualty incidents, when you have basically 5 or more, but it's not defined by number, patients on one scene, we defer to that as a multiple casualty incident. We're going to talk about that later on late in the semester. The documentation rules tend to change in that circumstance. Kind of throw all the rules out the door, but don't worry about that right now. For right now, we're just focusing on one patient at a time. We talked about what to do if you're exposed to infectious disease. You need to call your officer, you need to document it, you need to seek medical care. The only other thing, other documentation issues we'll probably talk about later on in the semester, specifically mandatory reporting forms for suspected child abuse. I wish there was New York State mandatory reporting for elder abuse, but that doesn't exist right now. I wish it did, but it does exist for child abuse or suspected child abuse. We'll talk about that later on. But for now, just be aware of it. All right, so and with that, I think that's all for now. This is just a recap of everything we talked about. So what's coming up? I'm going to stop recording here.